IBS podcast. I'm your host, Johanna Rubby. The podcast connects patients and providers with information and education about the diagnosis and treatment of IBS and related diagnoses. Each month, we feature a new episode with guest experts in the field of motility and neurogastroenterology who share the latest science and data for diagnosing and treating these conditions, as well as conversation about their impact on a patient's quality of life. Just a reminder, the information provided in this podcast is for informational and educational use only and should never be substituted for medical advice. Always work with your doctor to diagnose and treat your IBS symptoms effectively. Hi, everyone. Welcome to another Tuesday night IBS podcast session. This month of February, we're so pleased to be joined by our guest expert, who is Dr. Lin Chang. Dr. Chang and I work together through the Rome Foundation, and I'm just so excited to have her because her work really aligns with a lot of my own personal research interests. And so it's going to be a really fun conversation today. So in case you don't know Dr. Chang, she is pretty impressive. She is the Vice Chief of the Division of Digestive Diseases, Department of Medicine at the David Geffen School of Medicine at UCLA. And she's the co-director of the Oppenheimer Center of Neurobiology of Stress and Resilience, and also the fellowship director there within the GI division. So she does a lot of training and a lot of mentoring, a lot of teaching. Her interests actually focus on gastrointestinal disorders such as irritable bowel syndrome, chronic constipation, and functional dyspepsia. She's a funded NIH investigator studying brain-gut interactions underlying IBS. And in specific, her research is focused on the pathophysiology of IBS related to stress, early life adversity, sex differences, genetic and epigenetic factors, and the gut microbiome, and of course, treatments for IBS. So all of these topics we're going to be discussing with her today. Hi, Dr. Chang. How are you? Welcome.
Thank you for having me, Johanna. This is a real pleasure and an honor, so I really appreciate the invitation.
Thank you. Well, the honor is ours, of course. You have such an amazing background and history of research and treating patients with these conditions. And I'm just curious how you got started in this. What was it that drew you to gastroenterology in the first place, and in particular treating IBS? Because as we know, not a lot of physicians want to kind of specialize in that disorder. So what was it about it that drew you to it?
Yeah, it's a good question. I really have a different background. You know, as usual, a gastroenterologist may have wanted to be a surgeon at the very beginning. And I went into medicine because I like, more of the management of chronic illnesses. But I knew I wanted to specialize, and I was thinking about different subspecialties. But I enjoyed gastroenterology because it made sense to me, the pathophysiology. I didn't really know if I was going to like procedures so much, but I did. But I'm a type of person that I like to get to know things very well. It's more in depth, more than breadth. And so in GI, I did start working with a motility expert. And so that's where I kind of got introduced into GI motility disorders. But I really did a lot of general GI at the beginning. But I really knew that I wanted to do something more. And I had the opportunity to work with Emran Meyer at UCLA, and who has studied brain-gut interactions and IBS for a long time. So that's really how I got introduced into it. But I really love the biopsychosocial aspect. I like the physiology and the brain-gut axis. And I had to really train myself to really understand functional neuroanatomy way in the beginning. And then I, met Doug Drossman later on, and he really taught me how to take care of patients and really understand about the biopsychosocial model. But I realized that I like multiple pieces of information, and you integrate it. And I like really the whole person approach to medicine.
Yeah, that's great. So you started treating patients with motility conditions, particularly IBS. When did you start to maybe think, there might be some differences between gender and how symptoms are expressing in these patients? Maybe I should start doing some research into that. When did that all kind of come about?
Yeah, actually, it was because we had applied for our center, our group had applied for a grant at NIH through the Office of Research of Women's Health, and they were interested in looking at sex differences. And we knew that there was sex and gender differences in IBS. It was really more of a female predominant disorder. So we applied for that grant, and that's why we started studying it. And we are probably now in our 18th year or so. So we've been actually studying sex differences for many years. And a lot of people weren't studying sex differences, but it was particular our research focus and an area that we thought was very important.
Yeah. Yeah. So in 2001, you published, which is so crazy because that just seems like so long ago, right? But
20 years ago.
Yeah. Yeah. So you started looking at why women were more likely than men to report irritable bowel syndrome symptoms, as well as other things like chronic visceral pain, musculoskeletal pain, those sorts of things. And you really were looking at a hypothesis that female IBS patients were different than their male counterparts in symptoms related to the viscera and musculoskeletal systems. But it was all related to the menstrual cycle and sex hormones. And I'm curious, what did that data discover? What did that unveil to you?
And so my first grant was about IBS with the overlap of fibromyalgia, which is also another female predominant disorder. Right. So we recognized that it wasn't just about having increased sensitivity in the viscera or the GI tract, but also in the musculoskeletal system. So it's really much more of a broader visceral somatic type of entity, and that there was shared pathophysiologic mechanisms. But we found that now these surveys, the one that you're referring to is a survey. And so we have these large surveys, and a lot of times they were hypothesis generating. We were trying to understand maybe factors that we didn't understand, but we recognize that women and men report symptoms differently and a different severity, and women will report more GI symptoms and upper and lower gut. They tend to have more constipation. I think that's well known. There wasn't as much difference in quality of life, but women definitely will report more musculoskeletal. And, just like we see fibromyalgia, it's much more common in women.
Right.
So women are predisposed to these. People use different terms. It could be, somatic pain disorders or somatic syndromes or chronic pain disorders, but there is evidence that women have a lower pain tolerance to men, or greater sensitivity to men in many previous studies.
So how many, I mean, we don't need an exact number, but you said more women with IBS also report things like fibromyalgia or other somatic pain syndromes. Is that a pretty common coexisting trend that you see, that if a woman has IBS, she's also probably going to report other pain syndromes, or other, like chronic migraine is a big one that I see a lot for women who have IBS. Is that pretty common then for most female patients with IBS?
I think it's more common if they have more severe symptoms.
Okay.
As the severity increases, you see more comorbidity, and that's men and women.
Okay.
So there's studies that have looked at just symptoms, like say headaches, pelvic pain or musculoskeletal pain, and other studies actually look at diagnostic criteria. We're going to review the literature, partly do this working team on comorbidity. But in the past, it's been like, if you're going to use fibromyalgia as an example, if you use diagnostic criteria and you look at a group of IBS patients, 30% will meet criteria for fibromyalgia. You could also do the opposite. You could look at fibromyalgia, what percentage meets criteria for GI symptoms. What I found is, in doing research in fibromyalgia and IBS, that IBS, you could find patients with just IBS. And then you can find patients that have comorbidities, and they tend to be more severe symptoms.
Right.
In the fibromyalgia population, it was not that easy to find fibromyalgia only.
Really?
Yet a lot of them had comorbidities, because I feel that it was, Bruce Naliboff used this analogy that I've never forgotten, but he always talked about like a tuning dial, like on a radio. Mm-hmm. So if you lower it, you can find IBS patients, IBS only patients. But as you start moving the dial more and more, you see patients that have more of these comorbidities, and like fibromyalgia is over there, and they tend to have more coexistent conditions. Because it can be pretty debilitating. So that's basically what I found. So it's a range that you see.
So do you think that there's enough evidence now that there's a true physiologic component based on gender differences in terms of gastrointestinal transit time or visceral sensitivities, maybe even pain processing, and specific effects of estrogen and progesterone on gut function? Is there enough evidence now for that?
Yeah, there's animal data, which of course sometimes it's harder to translate to humans because their cycling is like 3 days and a woman is, a month. And sometimes it's hard, but there's definitely evidence of physiologic differences between men and women, but I do think it's more complicated than that. But studies with ambulatory monitoring that Satish Rao did in the colon and other transit studies, women, just healthy women, could have the slower transit time than men. If you add on the disease population, then you could see more differences. But so when you study sex differences and gender differences, you have to look at, is this just a sex and gender difference in general? So you have to study the healthy population, because maybe the finding you're seeing is just really the difference in males, females, men and women. Or is it really a disease difference? And is there an interaction? So is it that IBS women are different than healthy men and IBS men, but there's an interaction between sex and the disease rather than just looking at each? So that's a little bit of the challenge of looking at sex differences. Yeah. Are you going to look at IBS women versus healthy women, IBS men versus healthy men? Are you going to look at IBS women versus IBS men? Or are you going to look at an interaction of the two? So those are things to keep in mind. But I was thinking about just showing you one difference that like if you look at the brain imaging studies and looking at sex differences, and what's interesting is that men and women may respond differently to whatever task you're given, and they may respond differently. So some of the findings that have been done by a lot of my colleagues at UCLA is some of the older studies is a task where it's not really a task, but it causes them to respond to something, but it's balloon distension. So you put a balloon in the rectum or the sigmoid colon, inflate it, and measure the brain response. Mm-hmm. And if you do that in women and men with IBS, women with IBS will have more activation in these emotional arousal or sensory processing areas than men. Now, if you give them an emotional recognition task, and that's looking at neutral faces, angry faces, happy faces, men with IBS will respond more with activation of these emotional arousal and networks more than women. So what's interesting about that is maybe women consider a stimulus in the pelvic region more salient to them, right? Because they have menses, pregnancy. Where men, if they're responding to an adversary, that might get them to respond more. That's more salient to them. So maybe some of the differences, were really evolutionary, that we have all these years. It's different just thinking about the modern situation where there's more equality. But we're really hardwired from many years of evolution of what we've had to experience for survival.
Yeah. So you recently were looking at pre and postmenopausal women with IBS in a study, and you found that their symptoms did not decrease postmenopausal, which I think some people thought that they would. Like if hormones are really driving it, then once you're kind of past that high hormone level in your life, that your symptoms are going to start to die down a little bit. Maybe if you still have them, they won't be as bad. But that's not really what you found.
No, I will say, though, that it is a retrospective analysis of our prospective database. So we didn't have a huge number of postmenopausal women or men of comparable age, because we tend to study a younger population. But it showed that postmenopausal women with IBS will report a higher severity of their IBS symptoms than premenopausal women. But if you looked at comparably aged men, there wasn't really a difference in the men that were younger or older with their IBS. Now, this is not really an old population. per se. And I use old as I get older, what I consider old, it gets higher and higher.
I know.
So right now we're in an NIH grant. We're trying to really study the differences and look at hormone levels. We're doing ovulation kits. Do we really understand what cycle they're in? So now we'll probably try to get that data more. But I will tell you that the perimenopausal state, which can vary for women, and Margaret Heitkamper did a study on this, they are the most symptomatic, whether you're looking at GI symptoms or you're looking at other symptoms, just probably because there's a lot of fluctuation in hormone levels. But that is the time I think that women are probably the most symptomatic. And then when they get more in a more stable postmenopausal state, it's definitely probably going to be less. And I think she showed that in her study. But that's what our grant is. Like, why is it that premenopausal women with a high estrogen, that they are more prone to getting these chronic pain disorders?
Right.
But then when you are in a low estrogen state, that you can have greater symptoms. And that's where we're trying to study that more from the brain gut microbiome. Right. And what I've learned a lot is that estrogen has a lot of different functions, and they probably have different functions also at different times of your life.
Right.
Puberty, pregnancy, postmenopausal. So there's different, because it's all about survival.
Sure.
And so estrogen can have a stimulatory effect. It could increase your arousal. It's probably part of the reason why women may be more prone to certain conditions, including pain conditions that are associated with hyperarousal. But it also has an inhibitory effect. It can actually increase the opioid system, endogenous opioids. So it also has a protective nature. That probably comes into play during pregnancy and preparing for delivery.
Yeah.
And it also works on the serotonin system, which also has a cortical inhibitory effect. So you have these kind of dual purposes or multiple purposes. What we're hypothesizing is that in a low estrogen state, like postmenopausal or right before menses, where women have a lot of symptoms, is that you have an imbalance. So you have more of this stimulatory effect and less of the inhibitory effect. And that's why at the end, you will have more of a prone to have more symptoms. But we're studying that right now. That's our hypothesis.
That is so interesting. So do you think, and clearly this is conjecture, but do you think that at some point we might, as we better understand this and the role of the hormones, be able to kind of use hormone therapy to treat these conditions?
Yeah, that's always, Margaret Heitkamper did a study some years ago where she tracked menstrual cycle and found that healthy women and women with IBS right before menses, when your estrogen and progesterone are falling, that's that fluctuation. So it's not the steady state, it's the change, it's the withdrawal, that they'll have more symptoms, both healthy women and women with IBS. But women with IBS will report a higher intensity of the symptoms. And she also looked at women that were on birth control, particularly more the monophasic. So you're not reproducing the fluctuations, and they tended to have less symptoms. With GI symptoms. So sometimes I think about using that because they do that for pelvic pain syndromes.
Exactly.
Dysmenorrhea.
Yeah.
So that's an option, but I don't think no one's ever really studied that in a controlled manner.
Right.
The question in postmenopausal women, because you don't necessarily want to give them estrogen.
Right.
But what's interesting with us studying the brain gut microbiome, and there's really not that much known about estrogen and the estrogen metabolites in the gut. But in postmenopausal states, the diversity of the bacteria in the gut, the microbiome, is decreased. And the microbiome, the bacteria they receive these conjugated, estrogen metabolites that they have to deconjugate, and then they get reabsorbed in the system. And it's possible that in postmenopausal women, the bacteria that deconjugate and the enzymes are different, and they don't deconjugate the estrogen metabolites, and they're not much reabsorption. What I don't know is if you give them phytoestrogens or you give some other considered safe type of microbiome targeted treatment, could you be able to reabsorb these, deconjugated estrogens? I don't know if there's going to be some novel, safe type of interventions that are more creative that will help women, with symptoms.
Gosh, that would sure be nice. I think, personally, in the perimenopause phase that I'm in, I definitely see, like, for some reason, my symptoms are they're a little bit more heightened than they
Oh, they
were
have to
maybe
be.
5 to 6 years ago.
Yeah.
So
I,
I was kind of thinking, oh, maybe they'll get better once I kind of reach that menopause finish
oh,
line, but
but I
maybe
think they
not.
will.
Okay.
It's got to be. I mean, when you're going through these fluctuations
Yes.
where the body's
Yes.
going to get destabilized, it's harder to engage these protective mechanisms. I still
Yeah.
remember a colleague of mine, a friend of mine who is a neurologist who studies migraine, and people say, "Oh, can't eat chocolate." He says it's not so much what you eat; it's when you change your diet a lot.
Right.
So
Yeah.
maybe a little low, steady state of chocolate's okay. you know, maybe a whole box isn't good.
Not the
So
whole. Yeah.
it's really about stability, right? Equilibrium state.
Honestly, I mean, between night sweats and hot flashes and mood swings, and I need all the chocolate I can get. Yeah. So let's move over now from differences to the role of trauma and adverse childhood effects on these conditions. I know another area that you've done some work in, and I'm wondering, what was the kind of trigger for you to begin looking at this as a correlation to these conditions? We've heard, I think a lot of people have seen the TED Talks in recent years about the role of trauma on like heart disease and other chronic illnesses, but personally, I had not heard about its effect on GI symptoms and GI illnesses. So what was it that brought you to this?
Well, I was very aware of Doug Drossman's studies and others where they
Right.
looked at more abuse in
Right.
the GI population, not just in IBS, but also in organic disease or quote organic disease like inflammatory bowel disease.
Right.
But the other area that we study in our center is not just sex difference, but the role of stress. And that's like the name of our center. And
Right.
when I taking care of these patients, I really knew that stress played a large role in increasing the risk and also triggering the symptoms. So we studied, that's why I studied the cortisol and a lot of the stress response system. So that's part of the reason. But I wanted to expand it more out of abuse, but also into other early adverse life events in general, because there's a range of them.
Right.
So I just got interested, and there was research that they were doing more and more studies using questionnaires. You didn't have to do interviews. And there were large scale studies looking at adverse childhood experiences. In the United States, it really started in the Kaiser population, showing links to cardiovascular disease and obesity and depression and substance abuse and lung disease. But it's interesting, they never studied GI disease.
Right. Yeah.
So I've used different questionnaires to study early adverse life events. And a lot of what I've looked at also is animal models too, and that's helped the pathophysiology research I've been doing. But I do think it's really important. It's prevalent. Now, many people, this is the point that I think is important. Many people have adverse childhood experiences. If you look at that ACE questionnaire that they use, it's 60% of the general population. So it's more of the exception than the rule where you're going to develop chronic illness. It could potentially increase your risk for getting it. Doesn't mean that you're going to get it,
right?
But it increases that risk. So there's other factors I think that are involved, but it's prevalent. And what I think is important about it is it shapes who a person is. It shapes the experiences, and it shapes the responses. Yes. And the way I think about it, and I've had long talks with Doug about this, I think the most challenging part, I think, and there's many challenging parts of having IBS and other disorders of gut-brain interaction, but as a patient, it's the unpredictability of the symptoms. You never know when it's going to come. Sometimes there's patterns, but so the patient or the person as a protective mechanism has to always be on alert. And this is where some of that anticipation or even anticipatory anxiety comes. And I think it gets you in the same contextual situation as going through these adversities where it isn't something you did. You're almost, I don't want to use the term victim, but the perpetrator had that or whatever event happened. It could be, death of a parent, that's nobody's fault. They could have had a certain illness. But it wasn't something that you really had control over.
Yeah. Yeah.
And then same with when you have dealing with these diseases, that unpredictable symptoms and severe symptoms, you don't feel like you have good control over them.
Mm-hmm.
So sometimes that same emotional response, that stress response comes out that maybe is similar to what you've experienced when you were younger or even as a younger adult.
Yeah. No, I think you're absolutely right. I mean, for a lot of us with trauma histories, there is a lot of unpredictability, or there was in those situations, and you were kind of walking on eggshells, or you just didn't know when something was going to happen. And I think that's very much a similar situation with chronic illness and IBS in particular. And that it can be a feeling of helplessness and, if the symptoms are very severe and they're not managed well, that can really then drive that depression and anxiety too, which we know then drives the symptoms. So it's just kind of this like wheel that you feel like you can't get off of. And it can be very frustrating.
It's overwhelming.
Yeah, very much so. I wonder though. Oh, go ahead.
Joanne, I just want to interrupt, and I'm doing a little plug for you, but it's really relevant. Is that because patients don't really understand why they're having these symptoms?
Yes.
I think your book, Gut Feelings, Disorders of Gut-Brain Interaction with Doug, is very helpful. And I would suggest it to a lot of patients because the physician and the healthcare provider, they only have a limited time, and you can give them some resources.
Yeah.
But it's nice to have it in one place where you're explaining why people have these symptoms. What's the patient experience?
Right.
How do you explain these things? It validates, it's hopeful. And just having that education is really important, because then you can feel a little more equipped to proceed and learn how to manage your symptoms better. It gives them some empowerment.
Yeah. Thank you. I agree. Thank you. I'm wondering, what do you think about, because I mean, you touch on it a little bit, like doctors have limited time with patients, and you are gastroenterologists, not psychologists. And this can be really touchy for a lot of patients who maybe haven't dealt with trauma or grief issues, and yet they're driving their symptoms and they don't really make that correlation. So how do you kind of help guide your patients in kind of understanding the role that their past trauma or grief could be having on their health currently, in a way that they'll accept and then be able to move to some really productive management?
Yeah, it's a good question. I do think it takes more time.
Yeah.
And you may not do it on your first visit, because the patient has to feel comfortable. Also, you have to give a environment and a relationship where they feel comfortable.
Right.
I almost never directly ask about it. I probably never do. But what I do is I'm really just trying to get the story of the patient. So I'm just, I like things like, have you ever had GI symptoms in childhood? When did they occur, even if they were intermittent? When did you, develop the symptoms, when they flare? So I take these kind of milestone time points, and then I try to figure out what was going on around that time that could have contributed for them to get symptoms. And it may be early adverse life events. It may be an infection. So sometimes I'll just broadly ask about that. I don't ever really say word to use abuse, or, I might say stressful situations. I try to be sensitive to how I'm asking it, but I really want the patient to relay that to me. So I don't act directly. I just make it open to start that discussion. And if they start bringing something up, I'll start maybe asking questions to, have them elaborate a little bit more. But that's really how I do it more. And then what's interesting is sometimes after we finish and I start relaying back to them why they had symptoms, putting the story together and from a physiologic and symptom perspective, then they may bring up something that triggers them to say, oh, this may be important. But that's after we've engaged in conversation about the condition.
Right.
So it may just come at that time. But what I always say is, which I learned the hard way, if you're going to ask about this, you have to be prepared to know when you get the information, what are you going to do with that information?
What to do. Yeah, absolutely. Because that's pretty sacred information for a patient to reveal. So you need to be prepared to know how to handle that. And that's a really good point.
And now to ask if they look uncomfortable, like they don't have to say, because you want them to feel ready.
Right, right. I feel like this is just a plug for the use of narrative history taking. I think that can be so helpful with just kind of like guiding the patient, like you just said, like asking about infection, asking about GI illnesses in childhood, and just kind of letting them just kind of tell the story. And before long, you might see clues that can kind of reveal things that they didn't even realize. So I think that's really, I love that whole narrative history taking. I think that's been really beneficial for me as a patient. And I've seen Doug utilize it so well in his management of patients.
Yeah, agreed.
What do you think about trauma-informed care, knowing that a lot of patients, well, I guess patients with IBS, it's been hypothesized in some recent studies that they're 4 times more likely to have a history of childhood sexual abuse or trauma. And so knowing that they're more common than other patients, what kinds of things can you do to make sure that your care is trauma informed? And the reason I ask is because I think in GI, there's not been a lot of intentional thought around some of the procedures and things that are just commonplace in a diagnostic workup that could be triggering for patients who have this kind of history. And it just can be very, it can set patients off if there's not some thought behind why even a digital rectal exam is being done or things like that. So do you have any advice on trauma-informed care in GI?
I don't know if this answers the question, but I do think it's just good that when you hear information, first of all, you don't probe too much. You have to be very sensitive to picking up the nonverbal cues or verbal feedback from the patient and just making it comfortable for them, being supportive when you hear about it and not being judgmental, just taking in that information. I think it's also really important to determine whether or not they have had counseling about it, if they've addressed it. Do they feel like they would like to? Because you may want to refer them to somebody if they feel like it's playing a role or it's impacting the way they're responding. Or managing or how their perception or their quality of life, and giving some resources for that I think are helpful. I definitely think for rectal exam or something that's more sensitive, an intimate part of the body, like at UCLA, they ask us to ask patients for chaperones that are trained to be present. And then I always explain exactly what I'm going to do. And so they know exactly how I'm going to examine them. And I definitely think we should be sensitive to younger women that may never have experienced that. So I always do that. And if they're not comfortable doing that, I think that's fine. I don't think it's good to push anybody into something they're uncomfortable with.
Yeah, I agree. Okay, so wrapping up, and you're kind of in the center of a lot of research in IBS. Overall, what are you excited about in terms of research that's being done? And then more importantly, I'm curious what you think about the role of mast cells in IBS. We're hearing a lot about the potential influence of that. And what are your thoughts on that?
There's so much research going on right now and in all different areas. And I think the important part about research is recognizing there are certain mechanisms that might be relevant to one group of patients with IBS and other mechanisms that are more relevant to another population, even though they all have shared symptoms. But that it's important to remember that the body works together in concert. And even talking about mast cells are not going to exist by themselves. And the way I think about from more a holistic standpoint is that there's, a dysregulation in a lot of our adaptive systems, like the cardiovascular, the immune system, behavioral, GI tract. And they if they get disturbed or get dysregulated, it could affect people in different ways. So there are some patients where they have more of an enhanced immune response. It's not inflammatory bowel disease, but and mast cell is going to be one of those, whether it's really responding to foods or just having mast cell. Now, the question we always have is, what's the relevance? Is that they're having some increased immune activation, but is that actually playing a role in their symptoms? That's really what the key is. But we do know that there's a greater autonomic dysregulation with greater sympathetic drive, the fight or flight, less of the vagal or parasympathetic. And the vagal system is important in reducing pain and reducing inflammation. So that probably is linked to that. So I do think that I always just think of the body and any of these conditions as it's an orchestra, right? So the mast cells may be violins, but it doesn't mean they don't interact with the other aspects of the human body. And it may be one way at one time and a different way at another time. And it's really the body just trying to respond for survival purposes.
Right. Yeah.
There's probably a benefit for enhancing the the mast cell or immune response. You just want it to go back to the baseline, but maybe it can't go back to the baseline.
Right. What about practice pearls? Do you have a practice pearl for providers who are seeing patients with IBS? And then also a tip for patients who have IBS?
It's probably good for both people to think about what the other person is thinking too, and understanding each other's perspectives.
Right.
I think for healthcare providers, even though you have a certain period of time, it's always better, I think, to start with what brought the patient in, what is very important for them to get out of this visit, so that you're really focusing on what's important to the patient, and start with open-ended questions. And then you start recognizing what's important to the patient, what's the bothersome aspect of it. And then you kind of start honing into more yes or no questions while you're trying to figure it out.
Right.
That's what I would say from the history taking, and that there's a lot of literature out there to help guide what's the best diagnostic approach. You don't have to exclude every disease before you make the diagnosis. And there's a lot of treatments out there, and not everybody responds the same way. I do think it's important for healthcare providers to tell patients that they're giving certain treatments for treating certain symptoms, so that the patient is understanding why they're taking, how they judge if it's working or not.
Right.
I think for a patient, the more informed they are, I think the better. But you can read so much on the internet, and then they think they have this or that.
Yes.
And so that's, I think it's good for them to know the lingo and to ask questions, because sometimes healthcare providers don't, give it in a little bit more of a user-friendly way of understanding it.
Right.
So, but I would say preparation is really important.
Yeah, I agree with you. I encourage patients to try and be as prepared as possible, really, because there's such limited time and you really want to be able to get your answers to your questions. So really being prepared, having a little list to go off of so you don't forget key points. But I think also setting expectations is really important. So, if the provider is asking, why are you here and what are your main concerns? And then the patient can kind of set some expectations for what the treatment's going to deliver, or what the patient-provider relationship is going to look like. It's going to be better for both parties. So
this is all about the history.
Yes.
Everything's about the history. So the patient has to be able to provide a good history, and the healthcare provider has to be a good listener.
Yes. And the patient needs to be honest, because we see a lot of that too. So yeah. This has been so fun. Thank you, Dr. Chang, for sharing your hour with us. If you have any questions for Dr. Chang, please email me. We'll pass them along and try to get some answers for you. Don't forget to join us on Tuesday, February 8th at 7 p.m. Eastern Time, where Dr. Chang will be our guest for a live Twitter chat on the Tuesday Night IBS page on Twitter. So please join us for that. She'll be answering questions live, and we're going to have about 40 minutes of her time on Tuesday, February 8th. So we'll see you then. Please join us again next month for another guest expert and a new topic. Until next time, everyone, take good care. Bye now.
Bye.
Join us again next month for another episode of Tuesday Night IBS, and be sure to follow the conversation on our Twitter page at #TuesdayNightIBS. We host live Twitter chats on the second Tuesday of each month at 7 o'clock p.m. Eastern Time with our monthly guest, and encourage you to join in the conversation. In addition, check out our page on Facebook at Tuesday Night IBS and find video presentations provided monthly by our guest experts to further guide our learning and conversation about these important topics. See you next month.